have this final of our CRC mortality learning community. And I will just say the overall objective that we've been using for this entirety of this process has been to increase integration of interventions mitigating colorectal cancer mortality disparities and state comprehensive cancer coalition planning processes. So we're really at the entirety of this. And today we are going to be focusing on providing a real world example of a state cancer coalition that has integrated CRC mortality into their cancer plan, and also to increase some of your knowledge of tools for integrating those CRC mortality pieces into your cancer plans and into coalition work. And we also always are looking for you all to network with your colleagues across the country, which I think we are doing already based on having this that short breakout, but we'll have a second one later. So next slide. I did want to talk just through where we've been so that you have a good basis for what our speakers are going to be talking about with their cancer plans, especially if perhaps you have missed some of our five total. This is our fifth one, but we did a lot of focusing on foundational knowledge for the first, second, and third session, which you can see right there. And I'm going to cover a couple top takeaways from each session. And then this fourth and fifth session were really about applying what we've learned. So we will go to the next slide just to check in on each of these sessions briefly. So again, you're going to get a recording of this. You're going to get a copy of these slides as well, so you can always look at this. But those recordings are available as well as those slides from these sessions on the ACS4ccc.org website, and Liddy just dropped that in the chat. But session one, we really did a level set. We did mortality, CRC mortality 101, and we had Tyler Kratzer join us from the American Cancer Society. And those top two, that top number one right there is the objective for the session, while the second one I just wanted to focus on as more key takeaways from the session itself. And it's a very interesting thing. It's a complicated, as we all know, CRC screening and mortality is a really complicated screening process, and then also why mortality rates are a little bit different and we're seeing disparities. So that second point says CRC incidence and mortality have been going down due to knowledge of risk factors, screening, and better treatment options, but there are plenty of disparities that still exist. So it's great news that it's going down, but there are issues with people born after 1950 and a gap in screening uptake, specifically with those under 55. We do know that screening is the number one factor when we're looking at how can we reduce mortality generally. And then there's also a shift to advanced CRC stage at diagnosis that we've seen as well in the last about 20 years. 60% of the cases that are being diagnosed now are compared to 52% are advanced stage. So that would be stage three or four. And that's in 2005 that we got that 52% number. And then finally, disparities within certain groups. So when you're thinking about screening itself, whether it's accessible or by type of test, especially if you're in a lower resource setting like a FQHC, a federally qualified health center, or within a rural area or so on, you might be thinking of using stool-based testing. Others are using colonoscopy to a far higher degree, and you'll see that disparity between groups and different groups of people. And examples of those are Native Americans, Hispanics, and Asians. All of those have different levels of whether they have access to screening, the level to which they're screened, and the types of tests that they're using. So there's opportunities there as well. Next slide. So session two, we talked about timely follow-up to colonoscopy and CRC mortality. And again, I reiterate that screening is one of the main factors that we can really use to affect whether CRC mortality is being lowered. And so that first bullet again is the overall objective for the session, but I did want to highlight those top two takeaways that I pulled out from the session itself, which is completing a CRC screening test is essential, but insufficient by itself if you get a negative or abnormal test. And you should complete that follow-up, and it should be repeated at a regular recommended interval. So it's not like we often get screened once and that's that. So, really focusing in on that repetitive screening as needed at the recommended interval and the follow up if you're doing a stool based test. That is what a complete screening would be. And then there is evidence-based interventions to increase follow-up to a positive or abnormal fecal test at the patient, provider, and system level. So if you're working in coalition, there are options for you to engage with partners with that can increase that follow-up and follow-up to an abnormal or positive stool-based test is shown to be one of those disparities that directly affects mortality rates in different communities. Next slide. Session 3, we talked about CRC mortality and survivorship. You can see our speakers there, lovely, both survivors themselves. We have that objective in the first part of the slide. And then we really talked about how CRC incidence, as it's increasing, younger people, it's continuing to climb for them. And we're seeing also that piece where it's more advanced stage disease that's being diagnosed. If we're successfully curbing the CRC mortality rates, we're going to have more CRC survivors, and they have specific needs. And so from that, we also learned there are multiple organizations with resources, advocacy options, policy engagement for CRC survivors themselves. And of course, survivorship is always important in the context of the continuum of cancer care. And then last slide for me, I believe, is session 4. So this is something that we're going to, again, we're going to use a little bit of the things we learned in this session. This is the application type of thing that we're doing in this session too, where we talked about CRC mortality data in your community. And from there, we have that that objective right at the top. But we really focused in on this session about how it's essential to understand your community landscape to begin the successful work and affect CRC mortality as a coalition. And that includes all the different steps, whether that's follow up to colonoscopy, whether that's specific groups, whether you have a large Hispanic or Asian American population in your area that you want to affect, those kind of things. And then also following up by engaging with partners to reach populations you want to seek. And then lastly, that there are multiple tools that you can use to access data related to CRC mortality, and they can go down to the zip code level, the county level, and we'll be exploring again that CRC data dashboard in a moment when we have those breakouts as an option to help you. But we really got into that in that session. So we'll move on to our speakers, I believe. Yes, perfect. So our speakers today have no conflicts of interest to disclose, and we're so glad to have them today. And I will just their walk through their bios quickly before I pass it over to them to allow them to speak. So first we have Sarah Arthur, MBA, and she is a public health leader with nearly 15 years of experience advancing cancer prevention and control efforts across North Carolina. She serves as the program director for the North Carolina Comprehensive Cancer Control Programs and executive director of the North Carolina Advisory Committee on Cancer Coordination and Control. In these roles, she leads statewide efforts to advance cancer prevention, early detection, treatment, and survivorship initiatives through collaboration, policy development, and community engagement. And then our second speaker today is Larissa Williams, MPH, and she's a program coordinator for the North Carolina Comprehensive Cancer Control Programs within the North Carolina Department of Public Health and Human Services, Division of Public Health. She has been with the North Carolina Comprehensive Cancer Control Program since July 2020 and is the lead staff for the Early Detection Subcommittee for the State Cancer Coalition. So we're so happy to have Sarah and Larissa here so that they can talk through how they, without any prompting from us, have already incorporated CRC mortality into their cancer plans, why they did that. And I believe they're even covering a little bit of a data update as well. So I will pass it over to them and allow them to take us away.
Awesome. Thank you so much. Good afternoon, everyone, and thank you for having us and being here with us today. So, as Aubrey mentioned, it's Larissa and I. We are with the North Carolina Comprehensive Cancer Control Program. We are housed within the Division of Public Health inside of NCDHHS. Next slide, please. So just to give you guys a brief kind of overview of us and kind of helps tear into how our cancer plan is developed. Our background, our cancer coalition is called the North Carolina Advisory Committee on Cancer Coordination and Control. You'll probably hear us refer to as the Advisory Committee or A4C just because it's a mouthful of a coalition name. But just so you know, that's how you'll hear us probably mention it throughout this presentation. But we are a little unique in that we are a legislatively mandated committee. So we were legislatively mandated in 1993 to have a cancer coalition. And so through that, we have a general statute that requires us to have a 34 appointed member coalition, as well as a cancer control plan and serve as an advisory board to our North Carolina Central Cancer Registry, as well as provide an annual report to the NCDHHS secretary every year. Next slide, please. So as mentioned, we have 34 members that are appointed to our board, but we also have over 100 partners that are also actively involved in our coalition. So our 34 members that are appointed, they're appointed by the governor, mostly through the governor, and then we have 6 that are appointed by the North Carolina House of Representatives and the North Carolina Senate. So of those 12 positions, 3 of them are North Carolina House of Representative members, and 3 of them are North Carolina senators, which is can be a blessing and a curse. But we also, our membership includes the 3 NCIs, which would be Duke, UNC, and Wake Forest, as well as ECU or East Carolina University. But our membership also includes survivorships, the Department of Instruction. So kind of that broad spectrum and not just that healthcare representation. Then as also I mentioned, we also have over 100 partners actively involved in our coalition. So it's not just those 34 members. They, again, cover that entire spectrum of partners. Next slide, please. So as mentioned, we're not only through our CDC requirement have to have this cancer control plan, but also through our general statute. So our current cancer plan runs through 2025. We are in the process of revising our cancer plan and hope to have the new one released in November of next year, or not next year, of this year. So this cancer plan is developed in collaboration through our advisory committee, our North Carolina Cancer Prevention and Control branch, which includes our BSEP program, the North Carolina Partnerships to Increase Colorectal Cancer Screening, Wise Women, so kind of all this breadth of cancer programs, as well as some other internal programs like the Tobacco Prevention and Control branch. So it's developed in a wide breadth of partnerships. Next slide, please. So kind of just to give you a big high-level overview of how our planning timeline works. So this is for our current one that's being released. It usually takes us over 2 years to develop our cancer plan. So we started this current one is actually on a smaller timeline than we typically like for them to be developed on. So it's really been developed over almost a year and a half, but we started it back in March of 2024. I do want to give a brief shout out to Edna Hinsey. She is our one of our program consultants and the editor on our previous 2 cancer plans, as well as the one that we're about to release, and our burden docs. So she's the one that keeps us on track to develop this timeline to kind of keep us how things need to be done and the timeline for things. So a big part of our timeline that really takes a big chunk of our time is including those edits and reviewers from our outside partners. So taking that feedback and incorporating it and sharing it back out, and kind of that process of going back it through it all. Next slide, please. So colorectal cancer has been involved in one of our cancer plans since our very first cancer plan that was released in 1996. So we've always had colorectal cancer and colorectal cancer mortality highlighted throughout our cancer plan. When we were first released, we had much higher incidence of mortality rates of colorectal cancer. It was previously like our second cause of death of cancer deaths, and is now our fourth one. So we've actually seen progress on our colorectal cancer rates since we've had our cancer plans. Our cancer plans always include strategic actions as well as evidence-based interventions for everybody to take to help us work as that statewide initiative to lower the cancer rates. Next slide, please. So in between our cancer plans, we also develop a burden doc or a data resource guide. So this is usually released in between the two cancer plans. This current one was released a little late, so it was released about 4 years in. We typically like to release it 2.5 to 3 years into a cancer plan to provide that more updated data to our cancer plan, as well as some additional new resources that may came out. So our current cancer data and resource guide has a more comprehensive overview of equity and includes the various population groups, also as how our landscape is changing in North Carolina from being a little bit more rural to urban, and how that's affecting our screening rates, as well as some of the new emerging population groups that are happening as well. And I'm going to pass it off here to my colleague, Larissa, who's going to do a deeper dive into our data, as well as how we're actually implementing some of the colorectal initiatives in our cancer plan.
Great. Thank you, Sarah. Hello, I'm Larissa Williams, and as stated earlier, I am one of the program coordinators for the North Carolina Comprehensive Cancer Control Program, and it is a pleasure to be speaking with you today on some of our data for colorectal cancer and the work that Early Detection Subcommittee has done in this arena. So on this slide, this is an example of the beginning section of the colorectal cancer page that is in our cancer data and resource guide. And as you can see here, it gives a brief description on what colorectal cancer is. But for the sake of time, I will focus more on the mortality data. And so as you see on this page, it has just a brief intro on the data, what we use. So for example, it has on here the Behavior Risk Factor Surveillance Survey, or BRFIS. And so it explains here about those who were reported saying that they've had their colonoscopy. And then also we do focus on the risk factors. So you see on here age, polyps, the overweight or obese, smoking, family history, as well as chronic inflammatory colon conditions. And we also focus on survivorship, as you can see in this slide. Next slide, please. So this is an example of what we have in our data guide. So this is several pages. And so as you can see on the left side, we focus on the most current data that we received from the Central Cancer Registry, as well as our North Carolina State Center for Health Statistics, their office. And so here you can see that from 2008 to 2012, that the mortality rate dropped. And also you can see the incidence rates that are above. You can also see that on the other side, there's a map, which I'll give more data in the next slide. But you can see that we have several examples of the mortality data, as well as incidence, as well as survivorship, as well as we have charts, diagrams, and maps. As you can see on the far right side, we have the incidence rate, mortality rate, our late stage, as well as the percentage of people who are current smokers. And for the sake of history, North Carolina has 100 counties. So as you can see here, we just only have a snippet of a few of those counties. Next slide. For this slide, it shows a map of the colon and rectum cancer mortality rates from 2017 to 2021. At the time that we launched this data and resource guide, this was our most recent cancer data. So it's usually 2-year lag time. And so this map shows elevated mortality rates in the northeastern part of the state. As you can see, there's a 10-county cluster. We not only have on here the actual rates, but we give a little more detail to why. So I'll say in this example that in that Outer Banks right corner, that there's a county cluster, and there are several factors that contribute to this cluster, such as socioeconomic status, which would be lack of employment in the area, low income, low providers in the area, and so forth. So if you look on this map, our average rate is 12.6 per 100,000. And then you can see that in the light blue colors, that is our lowest age-adjusted rates of colon cancer mortality. And then the darker the color, the higher the rate. And we do have a few states that are in white, and that means that they have less than 16 deaths per year. And this was done in March of 2024. Next slide, please. And so the Early Detection Subcommittee, this is one of the subcommittees that's within our advisory committee. We also have prevention, care and treatment, and legislative and education. And so I'm the staff lead for the Early Detection Subcommittee. And so I have a snapshot here of our co-chairs, as well as our purpose, our vision statement, the priority areas that we are focusing on for the duration of the cancer plan year, as well as the interventions. And so Sarah showed you a snapshot earlier of an actual page that has the Early Detection Subcommittee for colorectal cancer, the rates, the objectives, those things. And so we are focusing on increasing cancer screening and early detection of cancer. Our main objective that I want to highlight is we want to increase colorectal cancer screening opportunities and cancer screenings through multi-component interventions. And so for the past couple of years during our current work plan cycle with our grant through CDC, we have focused on the Get Screened campaign, as well as patient reminders at federally qualified health centers. And I want to go back to what I mentioned in the previous slide about the 10-county cluster that I mentioned. And so with the Get Screened campaign, for 2 years, we focused on that cluster because we did look at the mortality rates amongst that region. As we broke it down with population, ethnicity group, how many federally qualified health centers was in that area, the screening rates, and then we developed a social media campaign in that region, our first year of getting that funding through American Cancer Society. And then also we added other regions of the state for that next year. So we focused on colorectal cancer for 2 out of the 3 years that we received this funding. And they also want to put a plug in that the partners that we work with that campaign and us assessing that mortality data was ACS. We also had some people that worked with the National Cancer Centers, nonprofit organizations, FQHCs, etc. So it was a broad team that worked on this effort. And then for the patient reminders at FQHCs, we partner with our colorectal cancer program that's funded through CDC to work with patient reminders at the FQHCs. And I can say that for that funding, that 2 of the clusters of the FQHCs is in the regions that does have the high mortality rates for colorectal cancer. And we have a lot more, but I know we're short on time. But if you have any questions, we will be free to address those. Thank you for your time.
Yeah, thank you so much, Sarah and Larissa. This is such a good outline of what people could potentially be doing when they start to look at the data and then also start to look at, how they engage their partners, who they should reach out to, and those factors that really affect whether or not someone will get screened and will eventually affect CRC mortality. So, yes, if anybody has questions, feel free to enter them into the chat as we talk through a few prepared questions for Larissa and Sarah. But really great presentation. Thank you all so much. And again, anybody feel free to ask some extra questions in the chat. But um, I'm just really impressed by your work, but I would love to ask a little bit about kind of the process of how you did some of these things. And overall, what do you feel, and Sarah or Larissa, or both of you, what do you think was the biggest challenge that you found while you were doing this work in your community?
Oh, I can go first.
Yeah.
So for the information that I shared, especially for the Get Screen campaign portion where we did like a deep dive of looking at the mortality rates for colorectal cancer, I would say that our biggest challenge was time because the funding was like a less than a year cycle. And then two, we did have a situation where we received the data a little later, and that was just only because there were changes that were going on through our our central cancer registry staff in that department. So that was like the two challenges that we faced. Sarah, you have anything to add?
I mean, I definitely would payback. I mean, funding is always a big challenge for us, just as it is for for pretty much all of comp cancer programs, and just really have to rely heavily on our partnerships to get any initiatives completed. I will also say another big challenge that we have with a lot of our initiatives is we are fortunate enough that we work with a lot of really high level individuals, the directors and deputy directors of cancer centers and presidents of organizations, which is amazing. But also, we're in the process of like, okay, do you have any staff under you that can also be the boots on the ground and implement some of this? Because at the end of the day, we are a small team and we can't do all the work. So that's definitely been a consistent challenge is having some more of those go-getters involved in our coalition and in our cancer plan work.
Yeah. Yeah, definitely. Leveraging partnerships, and especially you all saying too that you have some of those high level people, sometimes so hard to kind of corral and get on your side, but if you get them on your side, it's a great thing. Reversing that question a little bit, what are you most proud of regarding this work that you've done?
Oh, I can go first. I will say a couple things. So one, I will say like I said, we're in the process of revising our cancer plan, and so when we started having some initial fall group like planning groups, feedback groups on our cancer plan, we had pulled together different partnerships, and before we even told them that's what we're doing is talking about the cancer plan revision, they all just popped up and held up their current cancer plan like it was sitting next to them, and I was like, oh my gosh, you guys actually use it and have it next to you, and it was amazing. And then also in that same note, we have done a lot of work in trying to make everyone see their larger picture and how they're involved and included in the cancer plan. And so it's gotten to the point now where in a lot of our planning meetings for different initiatives, our partners are like, well, what does it say in our cancer plan? And so it's been kind of big, proud moments of us really working on integrating that into all the work. And now that our partners are now reminding us more than we are have to remind them, definitely are some big proud moments for us.
Yeah, that's great. Larissa, do you have anything to add or you agree?
I'm agree.
Yeah, no, I think that's such a that would be a very proud moment. I would also ask, I mean, obviously this is a long process for you all to get everybody on the same page and doing these things. Is there any tips or hints that you feel like you would like to share to the rest of the cancer coalitions on how to get them to use their be referencing their cancer plan or be on board with CRC mortality, CRC screening in general?
I would say just remember to keep your goals and objectives on the forefront. For example, the goal that you saw that I had, that's on the agenda for every meeting. Sarah has been good when she sent out announcements. She makes sure that our priority snapshots are included in every meeting correspondence, just so people can remember that what we're working on. So having a great goal and having the right people at the table. And I would say, be patient with the process. Sometimes it doesn't happen quick, but as long as you have the right people in the room and being patient and keeping the main thing, you should be fine.
Yeah, great. Anything you'd add, Sarah?
Yeah, I mean, like Larissa said, we kind of just drove home where any chance we could get, we made sure we referenced it back to the cancer plan, but we also made sure we got buy-in from our subcommittee leaderships. So each subcommittee has a chair and a co-chair. So we did a lot of meetings when we first released the cancer plan to making sure that they understood their part and how it's all involved, and they are also responsible for implementing this cancer plan. So we did a lot of leadership meetings with them at the release of the cancer plan, and that definitely helped some too.
Yeah. Well, thank you both so much. I do not see any other questions in the break or in the chat, but you've both been so informative on kind of how you prepared the cancer plan, sharing to your version that you've spread and people use, which is so inspiring as well. And so I believe we are going to go to breakouts